This is the representation of the kind of quality of speakers that we have here at West Hawaii Forum. And we put these monthly forums on to provide as much civic involvement and education on issues that are important to you, the community. We are one island. We are one community.
We are beginning our fall 2017 season for the West Hawaii Community Forum Series. And before we begin, just a couple of announcements. First of all, in your program on the back page, if you haven't seen it already, you'll notice that this is a list of all of our forums that we've had year to date. And I wanted to remind you that this is a valuable free resource for you. If you missed any of these forums, I encourage you to go to the website and feel free to stream on demand the forum, and also of interest, and also any of the speaker information is available as well. And that's in the past forums page of the westhawaiiforum.org, our community website. So here we are again, and I would say that first and foremost that we wouldn't be here, it would not be possible without the support of your donations. And we are an all-volunteer organization, and to that I want to first of all thank my board, which is here this evening, beginning with Jane Clement. Jane, where are you? No, she was here. Okay, and also Pete Hoffman. Pete, thank you. Scott Ordaway. Scott, thank you. Isaiah Hare. Isaiah, back on camera. Thank you, thank you. David Yap. David, thank you. David's new to our organization and is helping out with the media group, and we most appreciate it. Thank you, David. And I'm Bill Bugbee, president of the organization. We have our next forum scheduled for November 16th, and that's on sustainability. Now, sustainability is an interesting word because it means a lot of things to a lot of people. We're going to explore something a little different. Rather than we can eat healthy and we can live within our means, and those are key assets to achieving a sustainable lifestyle and a sustainable planet. But what we want to talk a little bit about here in Hawaii is a unique situation that we have as an island state. And by that I'm saying that we have a supply chain that if it is cut off from the mainland, we have food supplies for maybe 3 days. As a matter of fact, when the barge misses by 1 day due to weather or some other event, you can go into Safeway and start seeing the shelves go bare. So food is a big issue. Energy, Helco is still primarily a fossil fuel utility and imports all of its oil for the purpose of generating electricity. And we'll get into that in another forum sometime. We'd also like to think about the fact that there are better ways to do things here in making ourselves a little bit more sustainable and in these, particularly these uncertain times. So I encourage you to come in November. We're going to have a very interesting group of speakers. This evening, we are very fortunate to have our speakers beginning with Senator Josh Green, who has the unique distinction of also being a doctor. And Senator Josh Green currently serves as the Majority Floor Leader and Majority Whip in the Senate. He's a member of the Committees on Housing, Human Services, Tourism and International Affairs. And Senator Green represents Hawaii's 3rd district and served in the Senate since 2008. He was first elected to the Hawaii State House of Representatives in 2004 and served 2 terms, spearheading the movement to provide affordable and accessible quality health care for all people of Hawaii. He studied as sophomore at Penn State University and received his medical degree in 1997. Thank you, Josh. Appreciate it very much. Also, in the unique position of being both a politician and a doctor, Representative Richard Cregan. Thank you for coming, Richard. Richard is Vice Chair of the House Committee on Health. He was elected to the House of Representatives in 2014, and he's currently serving. His current committee assignments include the Consumer Protection and Commerce, Housing, Human Services, and Judiciary. He is a physician and a farmer, and he also graduated from Yale. Sorry about that, Buzz, who's a Princeton boy, and University of Connecticut School of Medicine. Joining Josh and Richard is also Buzz Hollander. Buzz has a very interesting story to tell us this evening about navigating through the rather treacherous waters of healthcare in the 21st century. Dr. Hollander has been a Big Island physician in both clinic and ER settings since 2005. While traditionally trained in Western medicine, he prefers the emphasis on healthy lifestyles and evidence-based prevention of illness. He graduated from Princeton and attended the UNC Chapel Hill School of Medicine before completing his residency at Santa Rosa Family Medicine Residency Program in 2005. And then finally, not a doctor, Kerry Kioki is with HMSA. And HMSA is the largest independent health provider here in Hawaii, and that is health insurance provider. And Kerry is a Director of Strategic Network Relations. He's been in healthcare in Hawaii for over 23 years, with 19 of those at HMSA. Kerry is responsible for supporting HMSA's strategy on development and implementation with physicians and physician organizations throughout Hawaii. And most recently, he has been involved in the development and implementation of primary care payment model that HMSA launched throughout the state. And that's something we're going to talk a little bit about today, is how doctors manage to survive in an environment where payment is uncertain or incomplete. And so hopefully Kerry can add some insights to that. And then one other item I wanted to add this evening before I open up to our presentations, and that is, if you have been paying attention, you may be aware that the Affordable Care Act, aka Obamacare, is currently up for grabs again in the Senate, and this time the Cassidy-Graham bill would add, and this is from a Center of Budget and Policy Priorities, which is a nonpartisan partisan research and policy institute, which analyzes federal budget priorities. Now, the CBO has not come out on this bill yet, so this is the first analysis we have on the current proposed repeal of the ACA and replacement with the Cassidy-Graham plan. In essence, the report says the analysis concludes that the bill will cause millions of people to lose coverage, radically restructure and deeply cut Medicaid, increase out-of-pocket costs for individual market consumers. It will eliminate or weaken protections for people with pre-existing conditions. It will destabilize the individual insurance market in the short term and make increasingly several federal funding cuts to the rest of the Medicaid programs in its per capita proposal. The result will be deep cuts to federal Medicaid spending for seniors, people with disabilities, families, and children, and other adults. Equally interesting is the bottom line. By 2026, which is sort of the date that this bill goes in terms of its full implementation, the Cassidy-Graham bill will cut Medicaid and other federal support dollars flowing into Hawaii by an estimated $651 million. Now that's significant. I mean, we're a small state. We have, what, 1.5 million people? You cut $651 million in federal funding, and that's going to have dramatic effects on our healthcare system and on individuals and families. So that is not a political statement. That is basically a fact. And I encourage you to talk to your senators and your House representatives about the ACA repeal that's being right now considered under the Cassidy-Graham plan in the Senate. So with that, I want to, again, thank our speakers, and we'll begin with Senator Green and his presentation. Thank you, Josh.
May I grab the clicker from you? There we go. Before I get this, I just wanted to say to these Yale and Princeton brats to my right that the head of the CBO is a Swarthmore graduate named Alex Minakazi, and she is a tough cookie. So if we do get time to get that bill scored, I could tell you it is a very smart thinker that I went to college with, and she was a good soccer player too. But she is a great healthcare thinker, and she's really going to do a good job on that assessment if it gets its day. So I wanted to say thank you, first of all, for having me. You know, I was reflecting on what one might say in general about healthcare before I get into our state circumstance. And from my perspective, and this is the perspective of just a citizen, not as a physician, not as a senator, my perspective is that we are the richest country in the world. We should be able to afford universal health care for our citizens, from my perspective. Now, how we get there, we can debate. But that is where we have to ultimately get, because if you're going to take care of your people on many levels, get them health care. So that was the first thing I wanted to say to us. Now, I'm going to dive into what goes on in Hawaii, and we know each other pretty well, so a lot of these slides, they're up there. Let's see, tonight's presenters, that's me. The reason I had that slide up there, it was about smoking. You know, smoking is healthcare. If we don't smoke, we save about a third of our healthcare spend through heart disease prevention and through cancer prevention. So there's so many things that we can discuss about healthcare. This would be one great thing to do, not to mention exercise and probably keeping our booze to a relatively normal amount, okay? So there's a lot of good things that we can do on our own in healthcare, and then there's a lot of things that we probably need some support with, and that is insurance. I grew up in Pittsburgh, went to these places, went and did missionary medicine in Swaziland, which was a little ironic because I'm a Jewish guy at the Nazarene Church and the Catholic Church in Swaziland for several months, but it was the experience of a lifetime because I got to see what healthcare is when you have a stethoscope and some free medications, and that is it. 56% of the people in Swaziland that I took care of were HIV positive. And our healthcare chart was not an electronic medical record, it was a 3x5 card. Pretty different healthcare system. And we took care of a lot of people. One weekend on a Saturday, me and 4 other volunteers who I went to med school with, we took care of, on that one day, 342 people that had malaria. So once again, healthcare is not always grinding it out at a hospital in an urban setting or in the Western world. And we provided a lot of real meaningful care. So things can be done differently. I came to Hawaii with the National Health Corps and got the honor of being the doctor in Na'alehu, where I've met people. I was even with someone today who I was her doctor years ago in Na'alehu. It was very gratifying to have that kind of relationship, which you can have in small communities. That's me at the hospital where I'll be starting a 72-hour shift tomorrow. And I think that was me after a 72-hour shift, actually. Unshaven and sleepy, but still plugging away. We're that short on providers, and so kudos to my friends who provide care and to work on the systems. We're about 40% short on the Big Island, 22% short on the whole for the state as far as healthcare providers go, and we have to work on that very significantly. You know, I went to the House of Representatives and the Senate. That's my wife, Jamie, there. She'd rather see me be a doctor than a politician, which is probably smart. But, you know, I take up healthcare concerns because that's what everyone's concerns are. It's not because I'm a doctor. We all need healthcare, and we have to figure out a way to get through this crazy system. 1.4 million people, as Bill mentioned, in our state. About 5% of our population is consuming an enormous part of our Medicaid. We went from 252,000 people on Medicaid to 365,000 people on Medicaid as a result of the Affordable Care Act, which I think is actually, in a way, something to be proud of because we took care of a lot more people. That's what we're going to be talking about tonight, though. The consequence of passing the Obamacare repeal, also known as the Cassidy-Graham repeal, would mean that Hawaii would have to at least go back or consider going back to where we were in the beginning, which was 100,000 fewer people insured, or decreasing the services to a broader number of people. Insuring people means keeping rural hospitals open. It means making it possible where it's already hard to attract a doctor or nurse practitioner to provide care, almost impossible if you have even fewer people that can cover some of the costs. And that is a huge challenge. Another thing I'd like to point out in this slide is we spend $2 billion on Medicaid. In our state, and I've done this study myself, just a very small portion of people who need care, 3.6% of those on Medicaid, so a tiny sliver of us, consume 61% of our total Medicaid budget. So that means 13 or 14,000 people who are sick or challenged with other issues, a lot of times it's drug addiction and mental illness and other chronic health disease, are consuming $1.2 billion a year. That's $82,000 per person per year. And we need resources for all of the people, and that's a great challenge for us. And it's something that we need to address, because I think we can do better by people and do better jobs with chronic care, chronic disease, and get more care for people. So these are some of the challenges. That is the reason I'm involved in everything. That little girl there, Maya, who dressed up as a nurse, I'm pushing medical school on her already. I really can't see my slide from this angle, but I can tell you that we're so short on providers, I'm training her to be a doctor already. This is the strategy for dealing with the healthcare shortage. We repay loans. Loan repayment, when we do it in the state, and I took this out of the playbook from the feds. The feds sent me here, luckily, luckiest move of a lifetime for me, to be the doctor in Nalehu and pay my loans back. I figured we should have that same program. We founded it in Hawaii. For every dollar that we spend on primary care, the feds will match us $1. And we finally funded it, thanks to the hard work of Richard actually getting the House to agree to this kind of thing, $500,000 from the state, another $500,000 from the feds, so we can attract healthcare providers. So we have to train docs, we have to train nurses, we have to erase debt, we have to expand our programs, and we probably have to increase reimbursements to primary care in general. The American Academy of Family Physicians showed that when you get the average compensation for primary care providers up to 70% of the specialty providers, then people start going into primary care. Now, it shouldn't be all about money, but we do need the primary care providers, as we all know here. How many of you have a hard time finding a doctor in the community? It's got to be a lot of people here. And we have done great things like start the community health centers, and we're talking about telehealth, but to get there, you know, it's going to take a lot of different plans. We did the good things in the state. We didn't use to cover craniofacial anomalies when kids had cleft lip. I worked with HMSA and they helped me create a way to do that, which was really great actually. There's Anya. She could get surgery because we did that in Hawaii because we're pretty progressive. Autism coverage. Again, that was Luke. We called it Luke's Law. We didn't have the ability to cover the care for children that were autistic. And now it's about 1 in 60 kids are somewhere on the autism spectrum. I have theories about that. You know, I have concerns about pesticides and what have you, for a different day perhaps, but we now cover. So when I look at the threats to the healthcare system, I wonder, what will it be? Will it be the repeal of a bill that provides care for everybody? Will it be a new system that has to develop? And we're going to have a lot of time to talk about these things. I would generally say we should lean towards single payer. Now, I have like 50 slides, so I'm not going to torture you with those, but I think what we need to do is we come up with creative models, and I think we're going to hear a very good one that Buzz has been talking about, but overall, we're not going to get there unless we have partnerships with the insurance industry, is my guess, and we move towards a way to actually find a way to get everyone insurance. In Hawaii, we almost have universal health care insurance. It's called HMSA, actually, and then you have Kaiser, which is another piece of the system. And they do work with the healthcare providers. Sometimes we fight, sometimes we don't, but there is a system in place. We don't have 20 health insurers like they have in California or New York. So it's an interesting circumstance. A couple more points. Homelessness is a medical condition. Now, I've said this to people before. The reason it is a medical condition is because if you're in Hawaii, if you're anywhere in America, your average lifespan is about 78 years. In Hawaii, it's actually 81. If you're homeless, your average lifespan is 51, 3 decades shorter. And when you look at what happens to homeless individuals, they are the very individuals I described earlier. they get beat up on the streets. If it's a woman, it's almost guaranteed she'll be sexually assaulted. If it's a young person, they will become drug addicted. And it's just a tragedy one time after another, and then they have to go to the hospital because there's nowhere else to go. It costs thousands and thousands of dollars. The average spend for someone who's homeless, like this gentleman, his name is Gary. He told me to share his name. He went to the hospital 241 times last year for $1.2 million. And it's because he doesn't have a home. He didn't have anywhere else to go. I did a study with Helping Hands Hawaii. The moment we get a roof over any individual's head who's suffering health issues, chronic homelessness, their costs drop 43% in Hawaii, 55% in Seattle and Los Angeles. So Gary's costs would drop $500,000 or more. That's healthcare reform in a different way. And then we could use that money for immunizations or for prevention or for drug and alcohol treatment. This is actually out of respect to a friend, we only treat 4% of the people who have drug or alcohol addiction in the state. I mean, are you kidding me? You know, passionate champions here in our midst today. So these are the kind of challenges that we have to take up. And so when I say solve homelessness, I'm also saying address healthcare discrepancies and healthcare disparities. I'll be working on that with national leaders. Getting people to stop going to the ER but to get a roof over their head, in my mind, is healthcare because they get better, their outcomes are better, they live longer, and they don't end up crashing the system. 30% of all of our ER visits now are from homeless individuals. They're just having a tough time. And they probably have some mental illness after being on the streets, and they're certainly self-medicating. And we're all aware in all of our communities, whether it's here in Kona or Hilo or certainly Oahu. So these are things I'm passionate about. I won't get into too much detail because it's a whole nother, it's a whole project, really. And we're creating, actually HMSA is sponsoring an idea, an initiative I have to create a health center called H4 on Oahu, and we'll export it around the state. H4 means hygiene center, it's bottom floor. Second floor would be housing. Second floor is healthcare. Third and fourth floors are housing, and it's a humanitarian mission. So H4. And we actually believe we'll save $35 to $50 million each year just by doing that. And people will live longer and get actual health care and not be on the streets. So when I see people on the streets like Gary, and I put their feet up on my lap and I work on their wounds as a volunteer doctor, they tell me their stories, and their stories are absolutely heartbreaking every time. So these are the people we have to help. And then there's one more health crisis, which I would mention. There's our solutions, H4. I'm going to give you these slides later. The other crisis is opioids. We just have too many pain pills out there. And God bless you, but if you're on pain pills for too long, you get addicted most of the time. If you have chronic pain, we need pain medication. There's no doubt, absolutely no doubt. But the system has gotten so out of kilter that when you get addicted, if you can't get your pain pills, you take heroin, then you're certainly addicted. I've spent so much time with so many people who have methamphetamine addiction who got there slowly. These are the healthcare crises that we have to deal with. And if we don't, we just pay the price as a society because we can't take care of the basics. We can't spend our time in clinics dealing with hypertension and heart disease and prevention and good diet and all of the things that we would like to focus on because we get so buried by some of these crises one after another. So that is my approach. You take on those big social challenges in healthcare while getting everyone insured. You do those things fairly basic, and we've got a great society and we can celebrate together. So, then we can spend time working on things like HIV/AIDS. We can start getting together as a family. So just thank you for hearing us. We're gonna have a lot of time together tonight. Forgive me for going a bit long. I'm very passionate about this subject, but please, let's find a way to come together, whether people are conservative or liberal. Let's make healthcare one of our essential services in the country.
Thank you, Josh. That was an excellent presentation.
Yes, because Richard has memorized all of Buzz's slides and is going to be giving his presentation.
When I went to Yale, we didn't have PowerPoint, so I'll have to go back to Swarthmore and learn how to do this. But anyway, that was a nice presentation, and I'm glad he did it because I don't have to do that. So as most of you know, I'm Richard Cregan, a physician and state representative for District 5. Thanks to Bill Bugbee and the Community Forum for hosting this and giving us this opportunity to discuss these issues, and thank you all for coming out here when you could be doing something else. I came to Hawaii in 1966 and trained for the Peace Corps on Molokai for 2 months, lived on the beach there. And, that was amazing since I was from back east and had never been, west of the wherever, some river. And it was great. It was wonderful. Then I went out to the Marshall Islands, spent 2 years on an atoll doing as a healthcare worker. And I'd wanted to be a physician, and, but that really cemented my desire to do that. So as much as I wanted to stay out there, I came back to America and eventually, went through medical school. And then 25 years ago or so, I came out back here, and I almost, initially my wife and I were gonna think about working at North Hawaii Community Hospital, but we ended up at Kona Hospital, both of us, and she spent over 20 years there, and I spent a few years less than that there. So I did emergency medicine there, and then I did urgent care, and then I worked for the health department for a year. And now, and I've been farming, and then now I'm in the legislature, which is very interesting. Okay, so the main topic of this forum is doctor shortages. But that is just shorthand for shortages of the host of healthcare providers that make up a modern healthcare team. Now, when I was a child, one of 7 children, we had a pediatrician who would drive out to our house from the next town with his little black bag and treat the whole family, who at that point might be suffering from chicken pox or the measles. His only tools were a tongue depressor, a thermometer, a stethoscope, a reflex hammer, his eyes, hands, ears, and brain. He also sometimes had a syringe of penicillin, which he hoped he wouldn't have to use. I think I might have bitten him once. I'm not sure. Maybe it was his nurse. But he didn't bring the nurse with him, though, so maybe in his office. So today, healthcare is an amazingly complex and expensive enterprise. The physician is only part of a team. That team includes increasingly nurses and nurse practitioners, physician assistants, clinical pharmacists, psychologists, and other therapists, clinical social workers, physical therapists, occupational therapists, and then another host of diagnostic personnel, such as library technicians of many specialties. The X-ray techs have morphed into a large group of imaging specialists who, in addition to X-rays, now have CAT scans, MRI scans, PET scan, ultrasound, and on and on. Physicians themselves have become increasingly specialized. There are specialists and subspecialists and sub-subspecialists in many of the medical and surgical fields. So we have shortages not only of primary care physicians, but we have almost no specialists, and certainly the subspecialists are not here, and often aren't even in the state. So it's a real problem for Hawaii. There's a shortage of all these people in Hawaii, which is only more pronounced on the neighbor islands. Neighbor island patients must travel for tests, and then travel again to have those tests explained. And it's really not fair. So we're not talking just about a doctor shortage, but of a shortage of just about every aspect of the medical team. I want to talk about a partial solution to this problem, which is to grow our own healthcare team on the Big Island. A part of that solution is to have a new medical center on the west side of Hawaii that I've called a University Teaching Hospital, but so much medicine is outpatient, we were really talking about a medical center that would in turn be part of an island-wide medical system. Doctors are mostly trained in the hospital in what are called residencies that can last from 3 to 7 years and be extended by fellowships. But I'm proposing that since we need a new hospital on the west side, and we really do, we've needed it for a long time, that we swing for the fences and try for something much more substantial, a full-fledged teaching medical center. So I'll tell you how this idea came about. I attended the 50th anniversary of JABSON, the John A. Burns School of Medicine, in July 2015. And during the speeches, something came up several times. That JABSON did not have an affiliated university hospital, as almost all medical schools do. And because the established Oahu hospitals did not want that competition. One reason their cancer center is failing because the cancer treatment people didn't want the competition, so they can't treat people there. Anyway, I met with the dean of the medical school, Jairus Hedges, and he liked the idea, invited me to present the concept to his leadership team. To me, so I pitched the idea for the House leadership. They knew that the state hospital system was going to transition to something else in support of the concept. And my office manager, Napua, and I met with the med school leadership team for most of an afternoon, and at the end they were very enthusiastic. So, to me, the most logical place for such a hospital would be out near the airport, and across the road from the airport was Palama Community College on 500 acres of state land with another 800 acres of adjacent state land. It had great road access, and the airport was right there. So that's where we proposed to put it, and that appealed to the leadership in the legislature and also to the med school, and also to Queens. They asked me to talk with Art Ushijima, the CEO of Queens, to see if he would be willing to consider partnering with them, and I met with Art and his team. They liked the idea, but wanted a feasibility study. So in 2016, with the help of Nicole Lowen and Josh, we got $500,000 for that feasibility study. Thank you. I met this week with Dean Hedges, and he's still on board and hopes to get that money floating shortly and that study done. He's willing to have Jackson head the team that does that study. Now, this will be a huge project, a big project. The idea of teaching a medical team is growing. Cleveland Clinic is building a $500 million building that will hold 2 medical schools, a huge nursing school, and a school of dentistry, all under one roof, all training and working together to learn how to work as a team in delivering the health care of the future. And that's what we aspire to do. I envision this medical center not as a medical school, but as a combined hospital and outpatient clinic that would train not only doctors and nurses, but clinical pharmacists and many of the healthcare providers that I mentioned that make up a team. John Morton, who's head of the community colleges, is enthusiastic about all the expanded healthcare programs that could be developed at Palamanui in conjunction with this medical center. And healthcare jobs are really good jobs. So how will this be funded? The land is state-owned and available. The state will provide some funds, of course. I propose to partially support that with a large bond offering with the interest on that bond paid by funds from the infamous TAT. And that bill was co-introduced by Finance Chair Sylvia Luke. So she was willing to share the TAT to fund a bond to build that new hospital. I mean, but that won't be enough. That bill stalled out as she wanted the feasibility study done first, and we do have the funds to do that. Now, the other piece of the puzzle will hopefully be private donations from the Gold Coast millionaires and billionaires. There's a lot of money out there across the road from the airport. John Morton said that when he went to talk to the Kukio people about donating to Palamanui, all they wanted to talk about was health care. And so I'm hopeful they will be interested in having a world-class facility on their doorstep. The new facility, as I envision it, will provide great resources for our existing physician and healthcare provider community. I mean, people that come here often leave because the resources aren't here. They don't have the backup. You know, they feel isolated. They don't have people to talk to bounce things off of. So this will be a resource for that, for our current physicians, so they may stick around longer. It'll also be a place that will also continue medical education, appropriate and pertinent to our island and state. I'm hoping it will become, among other things, a center for excellence in the diagnosis and treatment of things like rat-lung disease and other unusual diseases that affect Hawaii, such as leptospirosis, brucellosis, and Hansen's disease. We need to learn about our local diseases. And, you know, I know Josh runs into this all the time in his ER experience. Leptospirosis probably particularly. So, now just this week I attended with Josh a closed-door informational briefing about the possibility and implications of a nuclear attack on Hawaii from North Korea. One of the possibilities is that it would destroy as well as overwhelm the medical system on Oahu. Having a high-quality medical center readily accessible by C-17 transports, where you can fly into this airport, on Hawaii Island could be a critical asset for our state. And I want to use that to help sell this issue, because if their hospital is destroyed, they'll need this hospital. It won't be able to take care of everybody, but it could be a center that at least could supplement the hospitals that are destroyed, because they're not going to hit this island unless they have really bad aim. Which, you know, Rocket Man may have bad aim, I don't know. Anyway, so this new medical center will be a much-needed safety valve and provide potential overall capacity to back up Oahu. Oahu is totally stuffed. I mean, the hospital here can't always send people, really desperately ill people there, because they're full. They can't take them. Okay, so Josh mentioned telemedicine. Telemedicine is here now. Telesurgery is here now. You can operate on somebody from hundreds of miles away with robots. It will be possible and possibly preferable to be operated remotely by a highly skilled surgeon, hundreds or even thousands of miles away, and the military is doing this. So this medical center should be developed with those prospective uses in mind, as they will be a significant part of our medical future. At the very least, this medical center should combine access to the best telecommunication and telemedicine with real-time consults in areas such as cancer treatment, infectious disease challenges. Mental health and psychiatry and medical and surgical subspecialties, which are often available on this island, could be supplemented. But I think this envisioned new medical center would include specialists here on the ground. It could certainly benefit from expertise not available on our isolated island state. Now, some of the things that we would really like to have, we might not have initially, like cardiac care, you know, an adolescent psychiatry ward, but those are things that hopefully will be done. It's going to cost a lot of money, but I think there's enough money in the private community that they will see the benefit of this and, name a building for themselves or whatever. But I think it can be done, and I'm looking forward to fighting for that for the next few years. So thank you very much for hearing that. And thank you for saying the other stuff I would have had to say otherwise.
Here, Buzz, let me give you this. Thank you.
Maybe you need to go off it, and then we'll see. All right, I think this is working. Let's see if this will too. Oh boy. Let's try it this way. All right, that's me. My name is Buzz Hollander. I'm a family physician practicing in Waimea. I appreciated being invited to join this panel tonight, not just to join my old friend, Dr. Green, who I'm beginning to wonder if he will wear a scrub top to his very own daughter's wedding. You pulled it off, though. It becomes you, Josh. But this is also this question of healthcare on a national level in Hawaii is something that is occupying an increasing amount of space in my head these days. So I welcome the opportunity to join you and share our different perspectives. Mine is probably a little bit different coming as a primary care physician. I appreciated Bill already disclosing my background there because I can gloss over this slide, although it does mean that the fabulous joke I'd come up about the beard I grew out before med school will forever go untold. So moving right along to residency times, in 2005, I was finishing up my family practice residency in Santa Rosa, California, up in Sonoma County. I had always intended to be a family doctor when I decided to go to medical school, and that was still how I was feeling, and hence I was in that residency program. I was finishing it up and came to do a rotation with Dr. Gene Swift, an osteopath here in the Kona area. And within a couple of weeks, I had fallen in love with the Big Island, and more importantly, had fallen in love with Dr. Michelle Suber, a naturopathic physician whom I ended up marrying a couple years later. So it wasn't long at all before I was back, and she was living upcountry Hamakua. So I took a job in the new emergency department in Honokaa, and then soon after that was a clinic physician at the Hamakua Health Center, so the federally qualified community health center there in Honokaa. It was a marvelous opportunity for somebody fresh off the boat from the mainland to get a real glimpse into the people's lives that had been here a long time, and in many cases, many generations. So that I have many good memories of that time at the health center. I was there for about 7 years. 2012, though, we had a young daughter. We were planning to have another, and working full-time in a health center, which was the financial reality, didn't jibe well with my desires around being a father. So my wife and I decided at that point to start our own private practice up in Waimea, Iris Integrative Health, and we were going to continue on. She was going to keep being a fee-for-service naturopathic doctor, and I was going to carry along taking all sorts of insurance from my patients, and many of them came along with me up to Waimea. And I really thought that was where my story as a Hawaii physician was going to essentially begin and end. And it didn't work out that way. And I want to talk a little bit about my experience because I think it is a different sort of perspective as we muddle through some of these very hard issues that we're trying to address tonight. What happened for me was within a couple years of doing what is really typical family medicine private practice was that I started to not love being a doctor anymore. And the trend was, it would seem that every day I'd get into my car at the end of the day and I'd hang my head and feel like a failure. Feel like I had not done so many important things. Specialists I should have called back, patients that were waiting for me to be in touch with them, labs, x-rays, MRIs to review, not to mention charts, not to mention trying to run on time ever. And it was not a good feeling, and it was every day, and after a while you have to read the signs and know that things aren't working the way they're going. We reflected a lot about this, and ultimately what I decided my problem was not the stuff that you usually hear about in the media, which is Medicare, reimbursement levels, staffing, malpractice. It was that I realized I had too many patients to care for the way I felt like I needed to do a good job, and it was making things increasingly unsatisfying for me. So we looked at what are the ways that we can reduce our patient panel and survive financially. And we came to something called direct primary care. I probably could have entitled this slide Concierge Medicine, but I was worried you all might think I was a snob if I did that. And I'd rather you just be confused by talking about direct primary care, which is similar to what we hear about when we read about concierge medicine. The idea is that patients pay their physician directly on a regular basis, rather than paying premiums to an insurance company, which then reimburses the physician as they see fit to do. Concierge medicine, for what it's worth, is similar in concept. Typically, a concierge doctor will also still bill the insurance for every visit that a patient makes, but the fees are usually a little higher as well. But the concept is similar, that patients are paying directly for their health care, almost like a retainer basis with a lawyer. This is something that has some obvious advantages that most of us can see right away, and I could as well, namely, you have fewer patients, so your patients have better access to you. You can spend more time with them. You can fit them in quickly. You have more time to do all the things that make a doctor feel like a good doctor, talk with their cardiologist and do good exams. Physicians love it for obvious reasons, and the patients that are in practices like this usually enjoy it as well. Now, it's got some obvious disadvantages too. Primarily, we're now talking about additional out-of-pocket costs for a patient. There are some models where insurance companies have gone along for the ride and helped pay these premiums, but they are few and far between. So in our practice, that's an extra $125 a month the patient needs to come up with on top of their premiums to their insurance company. And that's not for everybody, and so given that we had 1,700 patients at the time, that meant over 1,000 patients were going to be going off into the community finding other doctors, which is why I don't know if Bill was fitting me for a black hat when he invited me to this panel. But yeah, you can certainly say, hey, this DPC thing, this is part of the problem, not the solution. But I want to reflect a little more on that because I'm not sure where it really stands in how we attempt to solve the issues we're facing in this state. For me, getting that patient panel number down was the only way that I could see loving my job again. I didn't want to be one of those doctors that retired early and went to work for a pharmaceutical company or something. So with that in mind, the number that I want people to think about a little bit more as we discuss healthcare policy is something that has only gotten much press, I would say, in the last couple years, but it's still widely ignored, and that is the size of a doctor's patient panel. So I call this the magic number, but I can't read any of these slides, so if I'm totally off, please tell me. But the idea here is that number of how many patients you have in your panel dictates a lot. And when you look at the basic math here that I did in my head in the car one of those days, it became obvious to me. If your average doctor works about 48 hours a week, 4 weeks for vacations and holidays and getting sick, that gives you at 40 hours a week, under 2,000 hours a year. And if your typical panel is around 2,300 patients, that's around what Kaiser caps their doctors at. So I think that that's a very typical number. It sounds like a lot to many people when they hear it, but there are doctors with 4,000, 5,000, 6,000 patients, so that's considered reasonable. But the math comes out to about 50 minutes per patient per year. And when I realized that number, it astounded me. Like, no wonder I don't like my job anymore. This is absurd. All of the face-to-face time with a patient, all of the notes I need to finish, the data I need to submit to HMSA and Medicare, the x-rays I need to review, the refills I need to call in, the discussions with other specialists, everything and more in 50 minutes a year? I don't think there's any way that a sane person can really attempt to meet a patient's deepest needs in 50 minutes. So that opens up a whole other can of worms. And in terms of what this can mean for this conversation tonight, we clearly could use more doctors. I did, as part of my punishment for taking on this panel discussion, force myself to read every word of the 30-page report presented by I think they're called the Physician Workforce Team. Josh and Richard may have even had something to do with the creation of that. So, no offense, of course, but this team was created, I think, in 2010, and there were about 2,900 full-time equivalent physicians in the state at that time. I think they've been working pretty hard. And after 6 years of coming up with something like an 11-point plan to try to improve recruitment of physicians to the state, There are about 2,900 physicians practicing in the state of Hawaii. So it's hard. And I don't know if anybody in this room has really got the answer as to what we can do to improve that. My thought would be that whatever we've been doing doesn't work. And one of the reasons why that is because primary care is unpopular in general in the country among American medical students. You can make a case for why that is. If a medical student, these are smart people, they're in medical school, they are now being introduced to primary care early on in their careers. That was supposed to make things better for primary care, but I think the problem is these people go and they spend a month with me and they watch me drive up in my 2002 Nissan Xterra. It's looking pretty good these days. And they see me calling patients all through my lunch and working until dinner. And then they go hang out with a radiologist or the dermatologist or the ophthalmologist. And, they're coming cruising up in their Lexus and they're, stepping out at 3 for their golf game. It's not irrational to decide that with their massive student debt, they don't want to go into this relatively low-paying, relatively thankless field unless they really have a passion for it. So I would offer that the usual thinking hasn't worked, maybe making primary care seem like an attractive thing to do to a medical student will help bring the number of doctors actually practicing up. And the other crazy statistic in that report, I hope somebody asks these two so they can answer it in the Q&A, is that they list 8,900 licensed physicians in Hawaii and say that only 3,700 are practicing right now. I would love to know what the other 5,200 are doing. I mean, are they all Starbucks baristas, or did they retire early? Have they gone into other fields? If some of those people could be enticed back into practicing medicine, I would have to think that would help our situation right now. And I think that's the way to do it, by making medicine something that's attractive to practice. We will hear more from Carrie about HMSA's plan, so I'm not going to say much about it. I would happily share more about my thoughts during the Q&A if anybody wants to hear them from a physician's perspective. They have done a really innovative and creative and courageous thing in this payment transformation plan, and no one's talking much about it. But they borrowed a little bit from the DPC concept in that it is capitated care. Physicians will receive a payment per month per patient, and then they've tweaked it by making that number go up or down depending on how the health outcomes fare. So in other words, are your patients taking their medications? Are their blood sugars going down? Are their blood pressures well controlled if they're hypertensive? So it's a radical idea that Medicare has been inching towards and is supposed to get to next year. I would point out that it will probably raise that magic number because more physicians will look at that and say, I was told the numbers are about $15 per patient. And say, wow, I want more of that, so I'm gonna take patients back in again since I don't have to bring them into the office to get paid anymore. My concern is that longer term, physicians are just gonna burn out at an even faster rate because until you make that number, 50 minutes per year per patient, go down, I don't see how a physician could be anything but burned out. But we'll hear more about it. It's a very interesting topic, and I'm glad that people are gonna get to hear HMA's view on what they're doing. The last thing that I'll touch on is that the other concept, and Richard spoke about this, and Josh spoke about this, so I won't spend much time on it, but yes, we need to train our own here in Hawaii. It's not as easy as just saying you want to do it, partly for what I said, that medical students don't want to go into primary care anymore. The numbers are down about 10% from the peak around 20 years ago. We need this to grow, instead it's heading in the wrong direction. But there are, I want to say 40 slots is what I counted out the other day, available for primary care residents graduating each year in the state of Hawaii. Nationally and locally, about 70 or 80% of residents stay in the geographic area where they train. So we want that number to stay high. In Hilo, I believe we have 4 slots, and that's all we have for the Big Island. So those programs rely on Medicare funding. And anyone that's been following what's happening on a national level, it makes a little nervous to know that that's the case. They can't survive without that Medicare funding for their residents. It's expensive to train residents. So keeping an eye on that picture and making sure that that doesn't go away, I think is really a critical point there. So all in all, I would encourage, as we look at this situation, which is really challenging, has never proven easy for anyone to solve, I think maintaining some creativity is important. Looking at that magic number as a way that, hey, it might be easier to recruit 3 new doctors to take on 700 patients each and get paid appropriately for that than 1 doctor to take on a standard panel, because boy, we're not attracting those 1 doctors taking on full panels very well these days. And my hope is that if we can bring those numbers down, we can bring the number of doctors up and make primary care great again. That's what I have to say. Thank you.
Thank you very much. First, I'd like to thank Bill and the Community Forum for having us, and really excited to talk to you all a little bit about HMSA. I've been, as you heard in my introduction, I was in HMSA for a little over 19 years now, over a span of a little over 23 years. So I'm actually very excited to be able to talk to you about HMSA and where we're headed. You're going to see in my slides here that it's going to look a little bit like a commercial for HMSA, and I apologize for that in advance, but I'm actually personally very excited to talk about this because I think we're a company that's headed in a different direction than what I think a lot of folks in the community and throughout the state have felt about HMSA. A little bit more about myself. I just wanted to say, born and raised in Hawaii, went to the University of Hawaii at Manoa, got a business degree. So unlike my fellow panelists here, I'm the only one that probably doesn't fit, being not a physician and also being born and raised here and going to the University of Hawaii at Manoa. But I'm also very proud of that, and I think that's why I've stayed at an organization like HMSA for as long as I have, because I really believe in the community mission we have. So the title here of my talk is Mahia 2020, and what that really means is HMSA started on a very transformative journey that we hope to culminate in 2020, and that's not by any means is the end of it, but we really have some specific goals that we're trying to get to by that year. I'm going to go to a mission and vision, and here is where it's going to sound like a commercial, but there's some key points in here that I want to point out. If you look at our mission statement, it's really to provide the people of Hawaii access to a sustainable, quality healthcare system that improves the overall health and well-being of the state. The key there is a lot of people think HMSA is very concerned only about HMSA members. I'm very pleased to say that we're actually looking beyond that. It's not just about our members. We understand that we're part of a larger community, and we need to focus on some collaborations. I think some of the panelists have talked about things that we're doing I can expand upon, but really trying to work with the entire state. And our vision, I'll talk about a little bit more, but there's a couple of things here. We're looking at unrelenting innovation, unprecedented partnerships, and uncompromising consumer focus. And that's really what I'm going to talk about and what we're trying to do in those three areas. So this slide, one of the keys here, and I'll go real quickly, but if you see on the side, we're focused on working with all of our different constituents. Consumers, providers, the community, employers, and the government. And I think a key here is that we look at ourselves as one of the stakeholders here and not at the center of this diagram. We really put the individuals of the state of Hawaii in the center, and we're all trying to figure out a solution to improve the healthcare system for everybody in the state. So as I talked about, the transformation that we're on. If you look back at sort of a standard health insurance organization's operational approach, it used to be focused on, the medical management, the tactical approach, really looking at utilization and medical management and just being an insurance company. What we're doing in our strategic approach is really to try and transform ourselves into a health organization. And to do that, we think we want to do three things. Create an integrated health system, and by integrated, I don't mean that it's everybody works for one organization. We're looking at virtual integration across the state. We're trying to align financial incentives, and as Buzz has said, we're embarking on some new payment models that we're rolling out into the community, and we really are focused on engaging the consumer. So in the three real initiatives that we have to advance the community health, first and foremost is payment transformation. We've embarked in 2016 on a pilot program to radically change the reimbursement model for primary care physicians. We started with a pilot in 2016 with 4 physician organizations, as Buzz said, to really move from a fee-for-service or pay-for-volume mentality to a pay-for-quality and a global payment methodology. We also worked and started to bring into the state other programs. We're the health plan sponsor for CPC Plus, which is a CMS program, and we are proud to bring that to the state of Hawaii. So some of our physicians have access to additional federal funding that they needed a health plan sponsor to be partner with. And we have a lot of community initiatives that we're working on. The second thing we're doing is integrated health management services. So when I talked earlier about an integrated healthcare system, we realized that it's difficult. I think primary care physicians, you've heard them here talk about, the difficulties to be a solo practice and to be out in the community by yourself, have your office and have to make ends meet. What we've tried to do is reach out to the different communities and figure out a way that we can provide additional resources. This could be in information, in technology, in processes, and in people. So we're investing in staff that, we have community health workers, we have care coordinators that we're trying to put out in the community to help physicians and the healthcare community advance themselves. And lastly, consumer engagement. So we've embarked on several innovative partnerships. I'll talk a little bit about one with ShareCare, an organization that we're strategically aligned with to bring consumer engagement tools to the state of Hawaii. We've heard a lot from our physician community that, HMSA is asking for change. We put a lot of requirements on our physicians around quality measures and asking them to do things like that was raised earlier, get a diabetic's hemoglobin A1C down, get your hypertensives to have a lower blood pressure. But what is HMSA providing that's going to work on the consumer side, on the patient side? And so we're really excited to bring what we think is a pretty innovative partnership to Hawaii. I'll talk about that more in a little bit. So I'm going to go into a little more detail about payment transformation. So this is sort of the journey we're on. We started, as I said, in 2016 with primary care. We did a pilot, and we've rolled it out to the majority of the primary care physicians that are participating with HMSA throughout the state this year. We also are starting to look at specialty payment transformation, and first thing I want to say is it's a completely different model than what we're doing with primary care. We believe that specialty payment transformation has different flavor depending on which specialty you're talking about, and we're not even confident that every specialty can do a transformative payment model. So we're looking at that. So we're piloting 3 different things in the state this year and hoping to launch more in 2018 and beyond. We're also talking to our hospital partners and looking at different ways that we can align incentives and align our goals moving forward and how we reimburse hospitals. Everybody, I think, one of the beautiful things about this journey that we're on is I think for the first time, I think we have pretty much universal agreement that the system itself is broken. Across the board. It used to be different facets of the healthcare industry felt it was somebody else's fault or it was somebody else's issue to deal with. I think we've all come to the table, at least from HMSA's perspective, and everybody's willing to at least come to the table and talk about different things, how they get reimbursed, the incentives that we focus in on. So that's the journey we're on with some of our hospital partners. And I think moving forward, 2018 and beyond, we'd really like to enhance those programs. The second initiative I talked about is providing resources in the community. And we have an organization within HMSA now called Integrated Health Management Services. And what we're really looking at, as I mentioned earlier, is 3 things: people, process, and technology. So we have nurses, we have social workers, we have community health workers, as I mentioned before, we have health educators, and we're really trying to provide some of the resources that maybe not everybody in the community has the capacity to hire themselves. The individual physician in a rural community, for example, may not have the resources to hire these types of physician extenders and team resources. So we're looking at trying to facilitate that and get some of our staff out in the community. We're also looking at some process and some technology. So what we've created is a physician-led decision-making body. We have a statewide physician advisory board and a physician clinical oversight committee where we have representatives from around the state that are physicians in the community that come together and help us design these models. So what can we do to help support processes around care management, case management, and some of the things that have been missing in the community? And we're trying to adopt those processes and then roll them out in the community through our resources. And lastly, technology. We're looking at different ways. I think one of the big barriers across the state is really that everybody's on different systems. All the EMRs don't necessarily talk to each other in physician offices, in the facilities. And we're trying to be a player in that and be a partner in that, knowing that we have such a big market share in the community. Hopefully we can be a catalyst to kind of integrate some of this data, and we have some strategies around that. The third initiative I mentioned is a partnership with an organization called ShareCare. What ShareCare is their mission is all healthcare in one place. I see people around the state, all different ages, all different races, everything. People walking around with their cell phones, and this gadget here has become something that everybody looks at first and foremost. I mean, before you even call your doctor, I bet a lot of people start to Google something and figure out, put your symptoms in here and think this will give you the answer first, and then you go validate it with your physician. We see that around the state. So, we really found a great partner, we believe, in ShareCare. And they put out an app, a ShareCare app, that they're really trying to integrate, again, all of your healthcare in one place. The goal is to have your health biometric data, your trackers for your steps and for your diet and your exercise, and really then access things like, ask a doctor, get a question answered, and eventually even connect it to your primary care physician and maybe make your appointment through the app. When you ask a question and you're having an issue and it tells you should probably call your primary care physician, your physician is then hooked up and then you can make an appointment. So these are things we're looking at and trying to really engage the community and the consumer through tools like an app in ShareCare. So this last slide, and I'll wrap up, and then we can talk about a lot of things in the Q&A about specific programs. But just to wrap up the conversation, this is our vision statement again. And why I brought it up is I really want to focus in on innovative partnership. Josh talked about the 4-H program that we're supporting, and that's just the tip of the iceberg. We're trying to reach out to all of the different communities. That's one of the reasons I'm here. I'm from Oahu, but I flew here because what we're trying to do is meet the people in their own communities and decide how we can be a partner and a catalyst to this to help affect change in healthcare. We know we're a big player, but we also fully understand that we can't solve any of the problems by ourselves. So we're here to listen, and we want to create innovative partnerships with the community, with the physicians, with government, with businesses, with all the constituents to figure out how we can solve some of the issues in healthcare that we see. Thank you.
I've asked Josh Green to do the moderation for the last half of our forum tonight. Before we begin, let me just say quickly that you have 3x5 cards, I believe, when you came in, you were given. So if you could just write your questions down on that, we'll filter them on up to our presenters, and we'll do our best job to answer those for you. And also, you have a survey document, and we really appreciate your feedback to hear on how we're doing and how we can improve, because we're here for you, the community. So with that, I'm going to turn over the Q&A session and look forward to what comes of it. Thank you.
You bet. So Buzz pointed out that we have had a much larger number of people licensed to practice in Hawaii than who do practice. One of the reasons for that is a lot of people come here already long retired, and they just want to keep a medical license in another state. So that's an artificial point as to why people aren't practicing. Now, would we like to bring people off the bench? Sure. And we'd like to have a lot more people come and stay and practice, and that point was correct. Those who get trained here stay here. It's 85%. Actually, it's higher than 75%. But one of the challenges, as you see and heard from our panelists, is who's going to take care of the patients. It's changing very dramatically. When Buzz recommended, or mentioned, I should say, that he trained under Gene Swift had just left Ka'u sometime before that. I was the replacement for Gene Swift. When individuals go and have practices with 700 or 1,000 people, if that works in their life, that's great. I inherited 8,000 patients. I became the doctor for 8,000 patients to run the Bay Clinic Community Health Center. And I certainly didn't do a great job for individuals in the way one would want, but otherwise you had no care at all. So one of the great challenges is if you have providers that are either burned out or choose to go into a different shape of practice, it is a great challenge for other pieces of the healthcare system. The people in Ka'u, instead of having 3 good doctors like Buzz, and actually the perfect solution would have been for Buzz to come to Ka'u instead, for Jean to stay in Ka'u, and for me to come to Ka'u. And then we would have had the solution. We would have had 3 doctors there all able to take care of those 8,000 patients, and I would have had 2 good colleagues. So it's a very complex situation, but it is a challenge for primary care. What I'm going to do is I've got a lot of terrific questions here. I'm going to go through questions quickly, and I'm just going to have people weigh in on them, because I noticed in a lot of our forums we have great questions we often don't get to. And then people should bring me their questions or shout them out, because let's get all these answers out here. First question was, is there a chance that the airlines could give a discount to those who have to travel to Oahu for a doctor? How many of you go to Oahu for a doctor at some point during the year? Cregan, what do you think? Is there a way we could do that?
I think it would be doable. I think Hawaiian Airlines is making a lot of money. You know, they have a virtual monopoly. I mean, there's some small players, but really they're running the table pretty much. So I think they would be willing to do that if it could be done, you know, in a way that you're really going to see your doctor, not to just go, you know, stay at some hotel somewhere. So I do think it would be doable. I think that's an excellent suggestion, whoever asked the question, and maybe we'll do something in the legislature to ask them to do that. Thank you.
This might be a question, this is a follow-up question. Carrie, do the health insurers sometimes help us with our flight costs?
Yeah. So I think in certain lines of business, they do. I think the issue for HMSA in particular is, you know, we're trying to be a good steward of the premium dollars that we collect from our employers and our individuals. And so there's a defined benefit package that may or may not include travel costs. But I think a couple other things that we're trying to do is really, I think you mentioned telehealth. I think we're trying to make it so that you don't always have to travel to Oahu for care. I think obviously that'd be ideal, right? Get the access to the care in your community. And so I think it'd be great to look at different alternatives, not just discounts on travel or benefits on travel, and then trying to get more specialists or primary care into your community.
I like that point, because I know that Richard's been fighting for enhanced telehealth. I think he may have even sponsored the bill in the last couple of years to make telehealth more mainstream, which has worked because HMSA embraced it and Kaiser embraced it. But up until last year, only 2% of physician providers and nurse practitioner providers were using telehealth so far. Now that it's mainstream, though, and it's going to become part of the model that Mahia 2020 and other providers are using in their innovative models, it could be a lot more relevant. And I actually found a psychiatrist for a family friend on Oahu. It's telehealth. I think they might have had one visit in person, but they're now having a very good relationship, and they certainly get a lot more care. Buzz, could more doctors come visit our island? You mentioned this, more often to provide care, to be recruited by you into your practice, to spend time spelling doctors. Could that work in your model or in your colleagues' models, do you think?
Yeah, I think potentially there's issues with having to be licensed in Hawaii, which is can be an onerous process. It's an interesting idea, sort of medical tourism, trying to entice people, physicians in on a part-time basis. You know, and that might be a small piece of the puzzle, but you know, you want your doctor to live here as a general rule. So I think the emphasis still needs to be on recruiting people that are ready to live here and be here.
Yeah, I think so too. And one of the things we've been trying to do is, as we get our hooks in people, particularly in the training phase of practice, if we can get them to either be a medical student here or a resident here for rotations, they will tend to stay here. The point of starting the HELO program, though it's only 4 per year, it's 12 right now that are getting trained, and we're expecting to have those individuals stay. Though the percentages are very terrible as far as our shortages go, the actual numbers, because we are still a relatively small population, are not as bad as it may seem. So to get 40 or 50 additional primary care providers here on Big Island over the course of a few years could make a very big difference. So we are trying to make sure they come, but they also have to stay, and they have to not retire, and they have to not have health crises. I've had physician colleagues who died at an earlier age. We had a neurologist who passed away years ago from a neurologic disorder, as ironic as that was. We lost him, and that was our only neurologist on the islands. I had a 43-year-old colleague die of a heart attack. We actually see higher suicide rates among healthcare providers. So it's something to be wary of because of those long hours that Buzz was referring to. When we have people that were working or trying to exceed their capacity at 60 and 80 hours a week, we have those challenges. Why do Hawaii healthcare providers face lower eligible fees from insurance carriers as compared to other parts of the country? Is that urban myth? Is it a challenge?
I think when we look at physician compensation across the country, I think we do see some disparities, but not as big as people believe. I think one of the big issues is, and it's a fact for everybody here, is that even if compensation were exactly the same, our cost of living makes it feel like it's a lot less. So, and one of the things in our payment transformation model, specifically for primary care, is we're really trying to elevate. So we're looking at national comparisons, MGMA, for example, to look at what physicians are compensated on average across the country and try to ensure that we're at least on par on average with them, if not higher, because we understand the community. Again, though, it's the same pot of money that we have to divvy up. So we have to figure out where that's going to come from, all of these increases.
Buzz, what was your experience?
I'll say that I didn't have any particular axe to grind with HMSA. They didn't treat me better or worse than any of the other insurance providers. I will say that I just came across a statistic researching for this discussion that someone that rated, it's true, HMSA pays around the average, maybe a little under, but around the average for physicians nationwide. But when you factor in the cost of living, they ranked out by state, and Hawaii came out 51st. I didn't even think there were 51 states in this country. But yeah, they count the District of Columbia. So it really is an issue in recruiting physicians. They look at this and say, really? You know, I'm going to get paid less here, and my rent or mortgage is going to be double what it is in North Carolina? Like, no thanks. So it's tough. But yeah, where does the pot of money come from? It's a real question.
Yeah, I would mention once again, I don't want to overly dwell on the loan repayment circumstance, but consider that a big piece of it too, because because our medical school is finite. We have 67 slots, I believe, in our medical school. It can only get so much bigger. It can't really produce a lot of doctors here, and they still have pretty high tuition, especially if you come from the mainland. The local tuition is much lower. It's going to be a couple $100,000 though. So the idea to get loan repayment into the system very thoroughly, from my perspective, is the grand solution. I'll just give you my case in point. In 2000, I came to Hawaii. I was a National Health Corps scholar. I came to fill that spot that was available in Ka'u. Yes, there were too many patients to take care of for a young doctor. Yes, I did my best. But each year, I was forgiven 1/4 of my debt, which meant that I did not have to at all worry that salary would be a matter. I never became a doctor to get rich. I actually liked the experience in Swaziland, where I was a volunteer doctor. I like the experience of taking care of a rural community. Don't like big boats or giant cars. It works out just fine in my life. But I did have those loans. And had I had $300,000 or $400,000 of loans, it would have been a 20-year commitment to pay them back, like having a large mortgage already. I couldn't have gone to Ka'u at least, where over 50% of the patient population, in that case it was like 60% of all the people were on Medicaid. So the practice just didn't work. 50% of all the people on Big Island are on Medicaid. So the practice models economically, the traditional models don't work, which is why HMSA has proposed an innovative solution for MAHIA 2020. Why Buzz is looking at an innovative solution to gather a practice that can make him stay in practice. And why we have Representative Cregan, why Richard is looking at having training programs to bring training doctors here to supplant some of the burden on healthcare. And why you look around you and you see some people who have done a great job creating the community health center. Community health centers are subsidized. When you're going to have these challenges with this many individuals, it's tough to have a practice that would otherwise not be able to attract a doctor. You have to have community health centers, you have to have a public health system. Now, it would only cost, and I'm going to say only, so please take it with a grain of salt, about $5 to $6 million of state monies and $5 to $6 million of federal match to have all of the loans repaid for primary care doctors that came to Hawaii, all, and nurse practitioners and psychologists. And the reason I say only is because we spend in Hawaii we spend $9 billion a year on healthcare. Yet just $5 million from the state would mean that we could attract any doctor or nurse practitioner to be a provider here. So priorities have to be adjusted. Another question, also in Hawaii, healthcare providers' fees are further eroded by having to send an additional 4% tax to the state. Sorry. This is one more reason why we cannot keep doctors. When will Hawaii join the other 49 states in exempting sales tax on healthcare? You want to comment on what happens at the Capitol, Richard?
Well, I mean, the legislature doesn't like to give up sources of income. And I'm not sure why that actually hasn't been pushed harder, why it hasn't passed, because it makes sense. But, you know, in my time there, there hasn't even been a bill on that. I mean, I would support it, but, you know, I'm just, you know, relatively small fish over there. And, you know, the finance people, the finance chairs, they don't like that kind of stuff. They want to, you know, keep that money coming in. So it's an idea. It's a great idea. It would be more equitable in a lot of ways, and maybe I should start fighting harder for that.
I think, and certainly not to put the onus on Richard, because he's absolutely right. I sponsored that bill several times, starting in 2005 and 6, when I was a young legislator in the Capitol, without these wrinkles and without the fatigue. And I did the analysis, and I had the bill writing people do the financial analyses. It's $120 million a year. We should absolutely exempt health care from the general excise tax because it's the most regressive tax we have, and you're taxing people who are in a vulnerable position. And $120 million is going to come out of someone else's hide. Really, it's going to come out of the Medicaid budget eventually, because that cost is going to get shifted over there, and the Medicaid budget is $2 billion. So one way or another, we pay it. So to put it on the backs of people in the healthcare system when we already have a shortage is probably not very sensible. But to get rid of it is to ask our colleagues to take $120 million out of the budget, and you know how difficult that is. But it is a problem. And it's yet another problem where if we are an outlier as compared to other states, if the cost of living is lower in other states, if the cost to do business is lower in other states, they may just keep their doctors there, as attractive as it is to come to Hawaii and have the license or come and make a life here. It's only about a 50-50 chance if someone comes and visits. You know how it is. You've seen a lot of friends come and go that wanted to experience Hawaii but just didn't quite take, right? And if you try to do that with a healthcare provider, we have to spend a lot of time training them and bring them over here, and they have expectations. It's challenging. Here's an interesting question. This is a different subject altogether. Cannabis, medical marijuana. Hawaii was one of the first states to legalize access to medical marijuana. 9 years later, and many doctors cannot or will not prescribe cannabis as a more medically effective alternative to more expensive prescription drugs. I'd like to talk more about prescription drugs in a moment. What's the solution to enabling patients' rights and access to prescription cannabis? When will insurance drug plans cover cannabis medication? Why don't I start with you, Richard, and we'll hit HMSA on when they're going to start paying for a little bit of ganja.
You know, the problem is, of course, that it's still a Schedule I drug on the federal level, and that, you know, presents a whole slew of legal problems for people. I mean, I think we're at the point where if you look at you know, I think this year we'll try and do decriminalization of marijuana because it doesn't make any sense putting people in jail, you know, and when our jails are full and our prisons are full for that. And I'm hoping we can push that. But I mean, eventually, I think the reasonable thing to do would be just to legalize marijuana in our state. I think it's quasi-legal already, but I think you know, the way that dispensaries are rolling out, they're failing. But if it was legal, fully legal, then I think physicians wouldn't have to struggle with referring it or recommending it. And I think people, right now it's the medicine, right? So people at the dispensaries can't do, you know, if they start talking about, you know, the doses and stuff like that, then they're practicing medicine without a license. So we might as well make it legal, and then anyone who's knowledgeable, and there are many people very knowledgeable who aren't doctors, could you know, recommend doses, strains, et cetera, et cetera. So I think the easy thing in many ways would be to legalize it and get rid of some of the problems we have with that system.
Has it ever come up in conversation? Carrie, I mean, you're at a pretty high level at HMSA. Do these kind of things get discussed? Like, are we going to treat cannabis as a medication now that in state law and with dispensaries it'll be available?
It has come up. I don't have a great answer for you, to be honest. I think we're monitoring what's happening both on the federal and on the state level, and we're going to react to the marketplace as it plays out. But I don't have a great answer for you right now on that.
Buzz, how's it affected you in your practice? You have a lot of colleagues around you, I know, that prescribe medical marijuana on Big Island.
And I probably would too. There's a little bit of a hurdle to clear in terms of you have to do additional licensing work with the feds to be approved on your DEA license to write for it. So I get asked that periodically. I support the use of medical marijuana and CBD. I think there's some limited studies, but it's Schedule 1, so there's not much research on it. So it's really hard from HMSA to say, yes, we want to pay for this as legitimate medicine because there's virtually no studies because you can't do research on it. So if it were easier, if I didn't have to go through additional certification and deal with more bureaucracy, then I would look hard at doing it. But that's why there's a limited number of providers that prescribe for medical marijuana, is because of the additional hurdles you have to go through, I think. Not to mention, the medical legal stuff of prescribing something that's illegal on the federal level, legal at the state level eventually.
Yeah. And for people who don't understand, I think most do, though. It's been very well discussed at some of our other topic discussions here. Schedule 1 is the most controlled. And it's typically reserved when a drug is called Schedule 1, it's for experimentation purposes. Now, personally, I think it's absurd to call marijuana Schedule 1. That is pretty much yesterday's news. I'm not saying whether marijuana is good for a person or not, but to call it Schedule 1 when it's been legal in some states and obviously used in many, many circumstances, we're talking about Schedule 1 is like LSD, okay? Very different kind of drug, which I'm sure some of us, I think my mom took some LSD in Woodstock before I was born, which is where I was born. But, it was not a part of the healthcare system. Marijuana is really a part of the healthcare system to a larger degree. And I feel, this is just one person's opinion, I think we have to evolve our thinking on medical marijuana. And I think we should probably be more understanding. The reason I say that is because I've seen so many challenges with opioids. When you have a lot of people taking a lot of pain medication, and they don't really want to. I've had so many encounters with people in the ER, believe it or not, where they say, I don't want a prescription for another 60 or 120 tablets. It's killing my liver and my kidneys, and I'm constipated. I have anxiety problems, or I have pain issues, which I feel, and the patient feels that marijuana would get them off of those pills. I think the trade-off is a good one at that point. I do think we should trust patients. It's not a simple question, there's no question, and I'm very reticent about marijuana in young people because they're developing still. Their brains are developing. But aside from that, people tend to make the choice themselves about whether they will use marijuana or not for their pain or for their other issues. We probably ought to move off of our conventional thinking. But you're right, if it's Schedule 1, pretty difficult. The state does not have the capacity to change scheduling, just so you know. It's the federal guys. And that is a grand conflict. Whether it was the Obama or the Trump guys or whatever, it's been a conflict for a long time. Here's a much larger question. What will the impact be on Hawaii if the Cassidy-Graham repeal passes? Would you guys like to consider that? We're a week away. The 30th has been the date set for consideration of removing Obamacare, setting aside, also known as the Affordable Care Act. It was mentioned, I think Bill was very eloquent in his description earlier about what it could mean. It could mean large cuts in Medicaid. We did an initial assessment. I'm the Human Services Chair, so the Medicaid budget goes to my committee. The initial assessment was a 40% decrease, 40% decrease of our Medicaid budget. That's where I believe Bill's number of $640 million would be. Can you imagine if that cut happened? What would we do? So I pose it to each of our panelists. What do you think will happen if to Hawaii if Cassidy-Graham does pass the repeal?
Okay, I think it would be disastrous, but I think our state would step up and replace as much as they thought was possible of that. I think that our state wants to provide health care for as many people as possible, and they would not, they'd be very reluctant to cut, especially the poorest people, which would be the ones being affected by Medicaid. And as you know, Josh has mentioned, opioid addiction is already underfunded. I think we would stretch to cover that as much as possible, but it would hurt other things. It's a zero-sum game. If you spend the money for this, then you can't spend the money for that. So maybe they wouldn't be able to air condition as many schools and things like that. So it's going to be a tough decision if we're forced to make it, and I hope we don't. I don't think it's going to happen, but if we're forced to make that decision, it's going to be a very tough one because there's going to be some trade-offs.
How would that affect you, Buzz? I mean, how many people are on Medicaid in your practice right now or in the community around you?
Yeah, well, a lot. I mean, my practice when we changed over about a year ago was probably about 20% Medicaid patients, and that probably had doubled after the Medicaid expansion. And some of it, I look at, it was clearly a great blessing for the people that were able to obtain Medicaid. People who had been struggling for real unavoidable reasons for a long time were finally able to get health care. And then there were also some people who were small business people who had moderately successful businesses who were able to, make the ledgers look pretty good from the perspective of being able to score free government health care. So I've seen a mixed response. When I talk to my colleagues about it, what they generally see is people that are really in need that are going to be struggling, because that certainly was the case before the expansion, where I would have patients who just, because of their disabilities or social chaos, were just not going to be able to afford insurance. They couldn't get a job to get insurance. And those people, when they were able to get health care, their lives got better, and it's going to be problematic if that gets pulled away. I think people are realizing that on a national level.
I hope so. Carrie, what would be the impact? HMSA, I believe you insure like 70+% of the state. So, and I know you take more than your share of the Medicaid challenge on. So what are you thinking?
Yeah, I think, remains to be seen what the true numbers play out to be. But if you read some of the information that has been released, the real shocking number to me is 32 million additional people uninsured is one of the numbers they targeted. And we believe you could say it's easy for an insurance company to say we want more insurance customers, but in reality, that's going to affect everybody in the community. And we really believe that this is not in the best interest of the people, definitely in Hawaii, and it's going to cause a lot of problems for us. And as somebody that wants to be a player with the entire state and the health and well-being, and to lose access for people, countless people, it's not good.
Yeah, and I would add to this. It's a very, very foolhardy gamble, in my opinion, and this is why. If, like or not Obamacare, if we do go down the road of having another 30 million, or back to the time where another 20, 30 million people are uninsured, people still get sick. People still get meningiomas, brain tumors. They still get bronchitis. Their kids still have asthma. So if they're uninsured and they come without a provider to the emergency department, they're just not going to be able to afford it. Now, first, some people, these are experiences I've had, they're just darn scared of a $4,000, $5,000 hospital experience. And they don't know. A lot of times we don't know how sick our kids are or how sick our parents are, but we know what the impact would be on our families. Devastating if we suddenly had a $5,000 or $10,000 or $20,000 bill. And to put people in that circumstance seems almost inconceivable, but certainly immoral. And I will see individuals in the ER, and if they can't pay, someone is going to pay for the services to keep hospitals open, and it's going to be the remaining people who are insured, which is all of the taxpayers. So I think it's really a shell game to say we're going to change the system and then make it more efficient, is what they say in Washington. I really don't think it's going to get more efficient if, instead of seeing a good doc like Buzz, even if I don't completely agree with his system, I know he delivers great care to the people that he has in his system. So if they have to instead go to the emergency department because they now have no capacity to see him, it's a disaster. It's a disaster for them. And when larger problems do arise, accidents, and you're in the hospital for a long time without insurance, there's just no way people can survive those kind of costs. And then finally, the rural hospitals themselves, if another 10% of our population can't pay a bill, I don't think those facilities will survive, which will affect all of us, insured or not insured. So we should be very careful about what happens. And that brings us to our next question. If there's large changes, could Hawaii create a single-payer model for the nation? Would HMSA start looking at insuring the whole state? Would they reach out to other insurers? Would a single-payer system possibly emerge politically?
I think there's a great desire on the part of a lot of people to have that kind of system. I think even on the part of physicians, there's a great desire to have that. There's a desire for, more simplicity, more clarity in terms of, getting paid or getting insured. And a single-payer system that was universal would be ideal. It's unfortunately, what you'd see in a system like that is there's some rationing of healthcare. We can't afford, the highest level of healthcare for everybody. So there would be some rationing of healthcare in a system like that. And people who had more money could get maybe the extra bonuses and get the plastic surgery and stuff like that that people on the regular system wouldn't get. But I think it could be done. I think it should be done for our country. Other countries, most of the developed countries around the world have done it. So, we could do it. We just have to have the will to do it.
There was a comment here, this was a follow-up comment on the same issue, which was raising taxes, would higher taxes, like in Europe, in countries like, I think someone says Sweden, and their handwriting is almost as bad as mine, I apologize, create better health care, and I think that's what you're addressing. I will say this, I ran the Universal Healthcare Task Force in 2006 as the health chair, and this was the data. I'm not going to say good, bad, or indifferent, but the data was, and we had the best people in the country come and do the analysis for us, for the state, if everyone was to be insured, it would require a 5.6% tax across the boards. Now, to break that out a little bit, though, that, of course, would mean while taxing people, all of us, an additional 5.6%, no businesses and no individuals would have to pay premiums any longer. So, for people who were making $0 to $90,000 in the state of Hawaii, they all had more money in their bank accounts each year. And they had universal health care and access from the system, up to $90,000. From $90,000 to $135,000 of earnings, people were in a totally break-even position. And for those individuals who were being taxed after write-offs in the usual tax system, from $135,000 and above, your taxes went up some. Just to give you perspective on what it would cost in Hawaii to do a single-payer system. Now, the devil would be in the details. When I was overseeing it, I felt immediately the likely process would be to reach out to HMSA and Kaiser and ask them to contribute their expertise on running a single-payer system in the state. Now, it takes a big leap of faith, but how many of you run businesses where you have to insure your workers? I was with someone today who runs a hair salon. She said she insures 8 workers because they're just committed to doing it. It makes it very difficult for them to stay afloat because of the healthcare costs. She favored a system like that. But those were the details, those are the specifics when we talked about a single-payer system in Hawaii. Lots of great questions here. What part can the Hawaii County Council play in increasing services to our residents, healthcare services? Kauai County is opening a psychiatric facility. The state is, of course, helping. How can our county help at the county level? Do I have council members here still? I know they were terrific to come early, and we hate to keep them here late. So they have a very rigorous schedule across the islands. What do you think? Do you think the county should get involved in healthcare?
Well, the hospitals here used to be county hospitals, okay, at one point, and at some point, of course, they started off as plantation hospitals, and they were county hospitals. And it was a county health care system, and I think to a certain extent, at least for the public health thing, maybe we should return to a county health system because I think what we're getting from the state, and Josh and I probably agree on that, is not very good, and it could be better if it was a county health system. But and I think the problem is the funding of that, and it would mean increasing taxes, and there's only so much the county basically has property taxes, so it'd mean raising property taxes to do that. And, or getting more of the TAT, which seems very unlikely the way things are going. So I think it's a matter of the amount to pay for that would be too limited to do it on a full scale. But I could see doing more of the public health and, in our county.
I do know, for instance, earlier today, I was having a conversation with one of our former councilmen, with Pete. And Pete was very passionate about the community health center as a council person, and I believe steered some of the resources from the county council to the community health center. And our community health center, which we started in 2005 together as a hole in the wall, if you remember, down in Kuakini, volunteer doc, a couple nurses, now it's got 160 people working there, providing care to thousands and thousands of our residents here in West Hawaii. And that is very local health care. It's very grassroots health care. And county politics tends to be more grassroots and more, from my perspective, in touch with some of these issues. And we rely on the state guys for the bigger taxes and the large projects, so maybe there is a place. A very good and specific question here. Is there a child adolescent psychiatrist available at Kalani Ola? What kind of services do we have? Can anyone comment on that?
I don't know. I don't think there is one. I think that basically child adolescent patients have to be shipped to Oahu, and that's one of the things that I would like to see if we had this aspirational medical center I'm talking about, that they would have psychiatrists training there and they would have a unit for adolescents there. It would be a small unit, but it could be done.
Buzz, in your practice, how often do you see behavioral health issues and mental health issues in the adolescent population?
Not that often, because adolescents don't come to see the doctor very often unless forced. And my practice is no different, so a pediatrician is going to see more for sure. I do think that does raise the question of the proper role of telehealth, which has come up a few times. It makes a ton of sense on this island. I use a virtual consult system. I hardly make referrals anymore. And the reality is most things, including something like adolescent health, it's weird. I know they do it at the Kona Institute, but having your mental health done through Skype is a little strange. That human touch is lacking. But in places where we lack specialists, it's a great way. We need specialists to do interventional procedures. We need cardiologists to do stress tests, gastroenterologists to do scopes. That's the stuff that we really need specialists here on island for. It's one way to reduce the needs of this community in this island is by really utilizing telehealth, because a lot can be done with records and Skype, telephones.
I'll tell you, the question of psychiatric care for adolescents is a big challenge. So when I'm on duty, which is too often, if an individual comes in under age 18 and it's clear that they have to be admitted for whatever reason, and usually it can be something heartbreaking, like a suicide attempt or a major drug overdose, very common stuff. But even if it's just suicidal ideation, which is someone's thinking about suicide, or a gesture, a conversation, it pretty much commits the healthcare provider to finding a place. A lot of times I'll keep people overnight for a night or two and have some safe space for someone in one of our little hospitals, our rural hospitals, because I feel like we're at least delivering the basic care. And a lot of times things do clear out in a couple days, but if there's going to be a transfer, it doesn't get to be to a local place, which means the kid's away from his or her family. And that's even worse. And it really can be a disaster. So I think that localizing care would be valuable. I'll come back to a point I mentioned earlier, which was our capacity to treat behavioral health questions, which is depression, mental illness, and drug addiction, is at about 4% capacity in the state. It is so low that one year, just as a statement, a gesture, I asked in a hearing to increase the mental health care budget by $400 million. And they all laughed. And then I said, well, you laugh. You go back to your community and laugh at a mom or a dad who doesn't have care for their child who's got an addiction to heroin. You go back and laugh at a mom or dad or a child that has tried to commit suicide. You ask yourself, don't you want to have a counselor or psychologist or psychiatrist? Maybe your $400 million better spent on that than some stupid rail project. So I think, we ought to assess our priorities a little bit. And there was silence in the committee, which is why they tend to hate me over there, okay? Because I I do want people to know what it's like on the neighbor islands if you can't find that specialist, even though people are working at 200% capacity like Buzz. But those are the kind of questions that we really have to ask as a healthcare system. I still hope that we can come up with some of the basic solutions. Whether it's loan repayment, whether it's new partnerships with HMSA or a teaching hospital, all of those solutions will make a very large and positive difference. But it requires that priority. It requires the priority to be health or human services rather than, say, infrastructure on occasion, or rather than maybe a contract. We have to ask ourselves, when does it help the greater part of society? And it really is not as complicated as people sometimes make out, some of the basic solutions. Of course, it gets complicated when we start talking about the details of healthcare and the complex medical problems, but we're just talking about having someone to see in our system or having somewhere to go. So I've come now, amazingly, to the end of the questions that were written to me already. Are there other questions that people wanted to ask our panel? We're almost at 2 hours, about an hour and 45 minutes in. Please.
Where is the camp going that's now in the old industrial area where all the people from the airport, they're now all there in this one space?
Yes.
Where is this going? What's going to happen?
Where's the homeless camp going?
And again, behavioral health is,
It's very large, right? The behavioral health. Does anyone have information on the homeless camp and where it's going to be relocated to?
My impression is it was going to be near here, but that was where it was proposed. I think it's just a proposal, though, so I don't think it's anything firm. But that's a county. That's a county decision. I'm glad they're doing something very positive and realizing that what they set up was helping so much that they needed to expand it. Yes. The question is, if you move it too far away from town, most of those people tend to eat fast food and things like that. They wouldn't have food sources. So I think it's it's a tricky question where to put it.
There's a concept in Hawaii called pu'uhonua, which is a safe zone. And it's something that I believe in and we fought for last year. Interestingly, the administration, who I'm getting along with fairly well right now, comes and goes, didn't support. Pu'uhonua, the safe zones, are meant to be a place where people can be safe and get some basic infrastructure and some food and have basic hygiene. And you can then safely come and offer, maybe accepted, maybe not, some basic services like healthcare services, primary care visits. In my estimation, it's a better way to go than to have tent cities built up that have no infrastructure and that are scattered and moved very frequently. There's no great and easy solution for people that are that are struggling that much. Once an individual has been on the road, or on the street rather, for more than 6 months, like I mentioned earlier, the probability that they have some mental illness or challenges is very high. And then it feeds to many of these other questions that we asked before. Do we have enough psychiatrists? We don't have enough primary care physicians. We're really short on psychiatrists. Psychiatry is another primary care discipline that is often even overlooked more than family medicine, like Buzz and I trained in. So these are enormous challenges, which once again, we have to ask ourselves, if 30% of our population, our communities, at some point have depression or mental illness at some point, or 10 to 12% of our population at any given time have drug addiction, do we not want to make that part of the mainstream primary care, non-judgmental part of our system? That, from my perspective, is one of the scariest parts of passing Cassidy-Graham. Because when it deprioritizes individuals who are suffering economically and zeroes out budgets for all of the individuals that are in our homeless camps and all of the family members that have drug addiction but don't have good insurance, you have to wonder what the impact will be. So I'm hoping that they have that discussion very thoroughly. I am told they're going to debate the bill for 2 minutes sometime on the 29th or 30th from Senator Schott, so I do consider a good friend. And he was angry about that, so I'm on Brian's side on this one. I'll tell you, Americans are going to have to rise up if our families are refused health care. I make a good living as a doc, which I'm honored to do through a lot of extra shifts. Not a rich guy, but I've got relatives that are very poor. and they're doing their best. Some of them didn't go and get a lot of education, and they work hard, and they can't afford health care if they don't get some support. I'm always going to help as a family member, as a brother, or as a dad, but I can only imagine what it would mean if that many people were suddenly the responsibility of HMSA to come up with another, 10%. So these are big challenges, really big challenges, and you guys have asked the right questions. I don't know where ultimately these solutions go, except to say that for homelessness, I do believe we should treat it like a health consequence and give people housing. Straight up pay for housing because their overall spend comes down and we save Medicaid dollars. So let's put some practical solutions into place. Any other questions? We got about 10 minutes left, or we can just wrap up and have kind of personal time.
I was wondering what HMSA was talking about as far as the payment plan, the changes you put in place. Does that apply for Medicaid for Quest as well, or just for private HMSA?
It applies across the board for Medicaid, Medicare, and commercial lines of business. And just real briefly, again, not to go too far, but what we really did was we tried to shift the payment methodology for primary care physicians away from, we heard a lot about burnout. We heard a lot about that treadmill and the number of patients you have to take care of and the number of visits you have to have every day. So instead of concentrating on paying for volume, we really wanted to shift it over where we're offering a global payment for each member of the panel. And that way, they can be a little bit more innovative. They can do things like telehealth, things that maybe previously weren't historically reimbursed. We're trying to encourage different ways of thinking and treating patients in that model. And it is across the board with all lines of business. Yep.
I have another question. This applies mainly to Medicaid patients that are, patients on Quest. Why is there only emergency care covered under Quest? Wouldn't it make sense to have preventative care for Medicaid patients, which again in the long run would save money, rather than just have people extract teeth? And then you have the issue of nutrition. There's like large effects when you just keep extracting teeth, and patients can't afford the root canal, can't afford fillings, and so forth after your afterwards. Why is there nothing being? At one point there was, and then it was taken away. I'm really kind of confused about that. Why is that not possible that HMSA cannot kind of, at least have some preventative care like teeth cleaning, just things like that?
So the question is, why is there not more preventive care in the Medicaid Quest line of business? And I mean, the simple answer is, the benefit design of the Quest program is designed by the MedQuest division of the state. But there are preventive health programs and benefits in the program. I think it's accessing the care, and it's getting patients to come out for those services. The question about HMSA's payment model, we do have a quality incentive program for physicians for Quest patients, and it's to look at things like cancer screenings and preventive care and doing other things, and it's not just for the emergency room.
Let me have you pause for a second. Were
Yeah.
you referring to dental care more specifically?
Here, like,
Oh,
Okay, sorry. I
Sorry,
think
yeah.
no, I think that the word dropped out when she was speaking. We didn't hear. So the question, I think, is for preventive dental care or for additional dental services. And I think that is a question that has come up very often. Children get some dental care, but in general, the cap is very low. It's been at about $500, which is far too low, as we know, to get any comprehensive dental care. And this brings up lots of questions, right? And I might as well, toss these questions out without trying to incite a riot. But people raise the question repeatedly: should we have fluoride? Maybe not. Maybe yes. How many people in this room would like to see fluoride in the water? And how many would be very opposed to it? See, it does tend to be somewhat divisive in communities. And I'm not judging. I don't know what the right answer is, but I do know that there is a good place for preventive dental care. I mean, my kids got it. We were lucky enough, and they've got pretty good teeth. They have better teeth than I do. So I think that these and many, many other public health issues are so central to what we need. Meanwhile, we're just fighting off. We're jousting just to keep what we've got, which is, in some cases, the most frustrating thing of all. Because just when in Hawaii, we're number one. We're number one in the country as far as being the healthiest state, yet we have all of these incredible challenges here on Big Island. It's hard to believe. We must wonder sometimes, what are the other states doing? Because I know that many times we wonder, when could we find a doctor? When could we find a nurse? Do we have a specialist in our own community? Yet we're still doing better than many others. We certainly have a long way to go, though. The Elite Health process has been pretty okay. They brought some specialists into the community. Kaiser brought some specialists into the community. But we're seeing lots of challenges. We have not seen a large surge. We've seen a small increase in the number of doctors. We've seen a lot of extra nurse practitioners in the state. And these are some of the larger questions. But Richard's been fighting on that issue. I have in the trenches. We've got good friends like Buzz. And then HMSA has been working very hard to focus on these primary care solutions. We have all of the challenges still, whether it's cost of living, our education system, bringing people here from the mainland, or dealing with the cost of training, all these things that we mentioned earlier, but they're solvable. They're solvable if we make those the priorities. Bill, did you want to, you were giving me a signal. One more question? Yes?
Oh, I'm sorry.
Yes.
I'm like looking at you for your question. Not to pick on HMSA, but I'm a year here to the island, and I'm an individual looking at HMSA. I have two choices, right? Kaiser or HMSA. But how can you sell a product if you don't have providers for your product? And I'm paying this, going to be paying this huge amount every month. How can you sell a product? I feel like I should get a discount if you can't provide me with these services I need.
So I think definitely the question is, how can HMSA and other insurance companies sell a product without access to the care in the community? And I do think that's a great question. I do believe that, HMSA, we look at our network adequacy numbers, we do have enough providers for our basic services. Do we have everything? Not necessarily, but not on island. But we're definitely, that's why we're working on different solutions, working with some travel benefits for certain lines of business, some traveling specialists to bring them into the community here, and we really are, and that's why we're here, trying to partner with everybody to figure out how we can all solve that problem. I don't think physicians are necessarily, just waiting around to work here right now, and that's what we're trying to figure out how to solve together.
Well, excuse me, but the second part to that is, okay, so you have to fly to Oahu. I mean, I'm sure people have been having to fly there for years. Why has this topic not come up?
Let me address that. So the question is, why, if this has been a challenge for many years, do we still have these shortages on some of these to fly to? Well, and let me address some of that. One of the reasons, though ideally we would love to have a totally contained system, a big island system, even if we maybe had to go sometimes to Waimea or even sometimes to Hilo, we've proposed centers of excellence, which we don't want to have redundant services because we can't afford that for sure. There are some actual reality challenges. We have a population of 220,000 people, okay? That means we will not have a neurosurgical team. Not because we don't want one, but because if you don't have a population of 500,000 people, you can't afford to have enough people and break, well, let me finish. So there are some services that we just can't have. And I had an uncle who died of a neurologic disaster. He would have probably died no matter where he was. His name was Jerry, okay, from a bad car accident. But he died on the roads here. We know when we come here there are going to be some limitations, but when someone has a cancer, we want to get treated here. When someone has a core problem, we want to know at least the emergency department will have good follow-up, and we can do better. We have these shortages. We will still have all of the challenges. However, it's my opinion, we would like to invest more in healthcare. It is so central to what we do here that if Richard can pull off what some people look as a Hail Mary, and I think is just plain a good idea to have a teaching hospital here, I mean, it is the right idea, because you will then have like a magnet to bring young doctors here, and it gives a more vibrant healthcare system. It's why it's such a good idea that he has. So this, combined with the other solutions, combined with keeping Buzz and his wife in practice and appreciating them, makes a big difference. And then we nudge HMSA, and they do meet us many times more than halfway on other solutions. But it's a big challenge. I don't want to go past 8, I promised, Bill. But thank you for having us, and I turn it back over to our host.
Let's give a good applause here for our speakers this evening. Josh, thank you. Thank you, Richard. Thank you, Buzz. And thank you, Carrie, very much. If you didn't see, and it's difficult to see up here, but these presentations will be on the website tomorrow, I promise. And by next week, Naleo TV will probably have this on their broadcast schedule, and we will have it on our website for streaming. So if you missed something or didn't quite hear a question, go to the website, westhawaiiforum.org. Easy. Thank you so much, and we'll see you in November. Sustainability. It's an important one. Thanks.
This is the representation of the kind of quality of speakers that we have here at West Hawaii Forum. And we put these monthly forums on to provide as much civic involvement and education on issues that are important to you, the community. We are one island, we are one community.